All right. Good morning, everybody. Good to see you. I hope you got your nerd hats on, as Danelle said. We're going to talk a little bit about assessment today. Let me get situated here. Here are my objectives. So I just want to go over some principles of evidence-based assessment, explore some of the barriers that clinicians often face when they're trying to use assessment tools in their practice. And then I'm going to very briefly and quickly go over some options for assessment tools you can use. And I've kind of categorized these into three different buckets. Symptom-focused measures, measures of functional improvement, and lived experience measures. But first, let's just talk about the elephant in the room. Many therapists and other mental health providers don't like outcome measures. But why? I'm wondering if anybody would be willing to share why you might not like or might not enjoy using outcome measures in your work. Do you have any brave souls?
It's difficult to quantify progress on an arbitrary measure. One measure doesn't adequately address all of the therapeutic growth that occurs in a therapeutic relationship.
I think you're absolutely right, Sean. Difficult to quantify, difficult to measure. The measure you choose might not capture the growth that happens. I like that. Any other thoughts about why you might not enjoy using assessment tools in your work?
I would,
I go for it.
oh, no, I was just gonna say for some clients, they either, um, what's the word I'm looking for? They don't report accurately, or they either, yeah, particularly with psychosis, their lack of insight, they don't properly report sometimes accurately on the screening. So, yeah, that's my frustration with it at times with certain clients.
Absolutely. I think I saw Heather's hand as well.
Yeah, I was just gonna throw in there. I've noticed with a couple of my people recently with reviews that have come up and just general assessments with them, it's just too much at one time. Not that we're doing it all in one session, but it's okay. You're here for, it's hard to get them to come in, and then when they're here, okay, we gotta just do one more assessment. So it's a
Mhm.
little bit boring.
Yeah, yeah, and I think
I don't know if that's not the right word, but that's probably how they feel.
no, I think you're right, Heather. Yeah, it can be viewed as boring or as overwhelming. Sandy, I think I saw your hand up too.
Actually, what she just said, and what
Okay.
I think it was Kimberly. In addition to that, I work with deaf people, and not a lot of tools have been normed for them, and so I always feel like they don't really apply. And I think for a lot of populations, you always wonder how are they represented in these outcomes. So
Very good point, and something worth considering, right? So, I mean, a lot of you said a lot of these barriers, right? Some of the reasons that people offer is that it feels like they're burdensome, time-consuming, too formal or mechanical, or that they might potentially damage the therapeutic relationship, or even just that they're a waste of time. And a lot of you work in settings where you're overburdened with responsibilities. And so adding outcome measures to your plate can feel like too much. And I think that these objections are understandable. And many of them speak to broader system related issues that continue to plague our professions and have been doing so for a long time. But it's also the case that the way you were trained probably has an impact on your attitude toward assessment. So, for example, research has shown that non-psychologists tend to be skeptical of the use of assessment measures. But today I'm going to argue that you should consider the idea of using outcome measures. It's still a valuable practice despite these barriers. What it really comes down to is one basic question. How do you know when the person you're working with is making progress? And just think about that question for a moment. Intuitively, you probably have some gut feeling about your work with many of the people that you work with. Informally, you might have even sought out some feedback from people. And implicitly, almost every helping professional has some sense of whether the work they're doing is actually making a difference. There's some internal benchmark that you're using. But your gut feeling alone is not necessarily a good guide. Evidence-based practice involves assessment methods and processes that are rooted in empirical evidence, not just a provider's hunch or best guess. There's also some real benefits to adopting evidence-based assessment practices. First, clients actually do want the results oftentimes. And when people receive feedback on how they scored on a specific measure, it can help them understand themselves better. And sometimes the results of a measure can confirm what a client might have been, what they suspect that they might have been struggling with for a long time. This can legitimize and normalize that person's experience. And also in the world of managed care, use of outcome measures can provide good data. The results might help you establish a justification for the need to start or continue services. So the rationale for using outcome measures is fairly straightforward. We want to answer one basic question: are services having their intended effects? And for this reason, it's important to track progress over time. So you can establish a baseline, determine where a person's at right now, and then at regular intervals, you can re-administer the measure and get a sense of how a person is doing in comparison to that baseline that you established. This allows you to see change over time. Now, outcome measures also help providers do better work. When clinicians receive feedback on a person's progress, it allows them to make adjustments. It also provides a pathway for clients and their service providers to discuss what's working and what isn't working. And then outcome measures can also be useful for things like setting goals, ascertaining a correct diagnosis, expanding a cognitive formulation, and it can allow you to highlight persistent themes and patterns that impact a person's recovery. And so the $10 million question I'll ask you now is, what is the best assessment instrument to use? Do we have any guesses?
The one that you're trained on.
That's right, Sean, the one that you're trained on, and nothing else, right? Any other guesses? The answer is it's you. You are a pivotal part of the assessment process. You impact what assessment instruments you choose, when you give them, the rationale you provide for giving them, how you score and interpret the results. Specific assessment tools can give you a formal way to evaluate aspects of a person's functioning, but don't forget to use your own eyes and ears. What you see and what you hear heavily influences every part of the process. Every question you ask, every answer you receive, it shapes the process. An assessment tool can complement your observations and your interviewing skills. It can highlight areas that you might have overlooked. So for example, in an interview, you might have noticed a person's psychosis symptoms, but overlooked the intensity of their depression or their mania. And an assessment instrument might be helpful in highlighting those aspects of a person's functioning. Now, using assessments can seem intimidating at first, but it doesn't have to be. To effectively use them in your practice, it helps to be familiar with a range of measures that you might use for the common problems you see in your work. And anytime you use an instrument, just be familiar with what it measures, like you said, Sean, or how to interpret its results. Also, think about how you plan to share the results with the person you're working with and how the results will be used to inform your service planning or your treatment planning. And in your discussions with clients, it helps to frame the results by helping them understand that outcome measures focus on a specific thing. The results shouldn't be construed as a global evaluation of a whole person. The results are used to help us better understand an aspect of a person's life. And so it helps to convey that to people so that they're aware of the limitations that these tools have. There's different types of measures that can be used. There's clinician-rated measures and self-report measures. Clinician-rated measures are those measures that you ask clients questions and then you rate them on a scale, whereas self-report measures involve clients completing the scale on their own. We're going to focus on self-report measures today. And one thing we know from research is that different types of tools are not equivalent. They each provide unique forms of information. And so if you can do both, it can be helpful because they complement each other. But for most agencies, time and cost constraints don't really allow for that. Research does support the idea that self-report measures, at least for depression, contribute more to the prediction of outcome than on clinician-rated instruments than vice versa. And so as a result, self-report measures are preferable if you can only choose one. And there are some trends in assessing psychosis that have emerged over the last 15 years or so. This involves the development of measures that focus specifically on assessing beliefs or interpretations of voices. These measures align with cognitive theories of distress related to voice hearing. And two measures that I'll mention here, the CIRATS and the BAVQ are some of the best supported instruments. There are also others, and we'll talk about one of those today, the BAVQ. So let's get into some instruments here. And like I said, this is going to be very quick and brief. First, let's talk about screening instruments. Now, these aren't outcome measures per se, but I think they're still helpful if you need to find out more information about a person so that you can make an appropriate diagnosis. So the Prime Screen Revised is a screening tool that measures subthreshold symptoms. It focuses on positive symptoms only. It should be used to identify people who are at risk of developing psychosis, not as an outcome or progress monitoring tool. The strengths of this tool is that it's brief, it's highly sensitive, and it has good specificity. Screening tools do often come with a higher false positive rate. When we think about the function of a screening tool, right, it's to capture people who might be experiencing symptoms. And so with this tool in particular, over half are likely to be false positives. So just be aware of that. The prodromal questionnaire brief version is a self-report measure that focuses on assessing positive symptoms of psychosis too. It allows clinicians to identify those who are deemed to be at ultra high risk for psychosis. And it should be used for those who are suspected of having attenuated psychotic symptoms. This allows for early identification and intervention to occur, and that tends to improve long-term outcomes. It's meant to be used as a first step in a two-stage process. You administer the measure, but then you follow up with an interview to confirm the diagnosis. Let's talk now about some symptom-focused measures. So I mentioned briefly the BAVQ. It's a 35-item measure that assesses people's beliefs about their auditory hallucinations. It was developed to align with the cognitive model of auditory hallucinations proposed by Chadwick and Birchwood in 1994. And in this model, it's proposed that people's emotional and behavioral reactions to their hallucinations depend not only on the content and form the hallucinations take, but also on the meaning the person ascribes to the hallucinatory experience. There's the cognitive biases questionnaire for psychosis. It was developed to measure 5 cognitive distortions that are common to psychosis: jumping to conclusions, dichotomous thinking, intentionalizing, emotional reasoning, and catastrophizing. It uses short vignettes to measure these biases, and higher scores indicate a higher likelihood of the bias being present in the person's thinking. The Trauma and Life Events Checklist, or TAIL, is a measure that was specifically designed to screen for traumatic events in people who have psychosis. One thing we know from research is that elevated rates of PTSD are found in people who have psychosis. And as a result, there have been calls to routinely screen for those symptoms in psychosis care. And in addition to typical trauma questions, it was designed to incorporate questions about events that are psychologically traumatizing too. And it contains items that assess a person's experience of trauma in the context of involuntary treatment. There's the brief hypomanic attitudes and positive predictions inventory, or brief HAPI. And this is an instrument that measures cognitions associated with bipolar disorder. And so it's based on a cognitive model of mood swings. And for those of you who work with people who have affective psychosis, you might find this measure to be helpful. Now let's talk a little bit about instruments that are informed by lived experience. And I think this is actually a very interesting form of assessment. So to better serve people with psychosis, there's been a shift and more effort placed on the goal of including the perspectives of people who actually live with psychosis in the development of these measures. And so the Subjective Experiences of Psychosis Scale, or SEPS, was designed to measure outcomes that are meaningful to people who have psychosis. A unique aspect of the SEPS is how it was developed. So the scale developers used themes from qualitative interviews with service users who have lived experience to draft the items, and then they presented an initial draft of the scale to the service users for their input. And so this scale is also unique because it asks service users to rate both positive and negative aspects of psychosis. That's something that's overlooked in many other scales. Most scales don't really acknowledge that people with psychosis can have positive psychosis experiences. There's the choice of outcome in CBT for psychosis scale. It's similar that it incorporated the perspective of service users in its design by developing focus groups. And the developers of this scale were trying to balance outcomes important to service users with the priorities of CBTP clinicians, so both parties. They're also seeking to create a measure that's brief and easy to use, and there is a short form linked on this slide here that you can use. We'll talk about one recovery-focused instrument. We emphasize the importance of recovery-oriented care in all of our training. And really, it's just the notion that recovery is possible and that services should reflect that belief. And so there is the recovery assessment scale. It's a recovery-oriented measure, and it was developed as an alternative to symptom-focused measures, which typically focus on deficits. This measure emphasizes strengths, and it seeks to capture outcomes that are relevant and meaningful to people who are involved in services. This is not an outcome measure per se, but I just want to briefly share a little bit of information about an implementation instrument. It measures an aspect of the implementation of evidence-based services. And while we often focus on assessing our clients, I also think it's important for us to assess ourselves. The effectiveness of CBTp is heavily influenced by the way a team implements the modality within an organization. So I just want to put a bug in your ear and encourage you to think about how CBTp is implemented in your setting. And so the implementation leadership scale measures strategic leadership behaviors that support evidence-based practice. Members of a team complete this survey about their team leader or supervisor, and it measures 4 domains of leadership: proactive, knowledgeable, supportive, and perseverant leadership. We don't have time today to go into the specifics, but I just encourage you to review this measure. It offers some insights that teams might benefit from as they seek to create the right conditions for CBTp to thrive at their organization. And so, like I said, this was a very brief review of some outcome measures that you can use. There isn't enough time to go into depth with any single measure. It's really meant to just give you some ideas of where to start. But I'd encourage you to review these measures, become familiar with them, and as you review them, look for key items that might provide insight into specific things that you're interested in knowing more about. So for example, if there are items related to suicide risk in a measure, you might pay special attention to those items just in case the responses suggest a need for more detailed risk assessment. Or for example, if you're using that cognitive biases questionnaire, you might pay attention to which cognitive biases your client tends to struggle with. You might develop interventions to target that more directly. It's also important to think about potential demand characteristics that might impact the results you obtain. I think somebody mentioned that earlier. Clients might be motivated to portray themselves in a certain way, like a good patient or maybe some other way that they want you to perceive them. So it's just good to be aware that that's going to impact the responses that you get. And finally, with any of these tools, I'd encourage you to think about the results not as an endpoint, but as a starting point for ongoing discussion. It's a way to facilitate the process of guided discovery, an opportunity to process barriers to progress, and as a method for focusing your discussion in your meetings with your supervisors and consultants. I did include an appendix at the end of the PowerPoint just to make it really easy to get a snapshot of what we talked about today. But are there any questions?